My talk today is about diabetic food issue in China and how the collaboration from South to Shanghai is cultivated. Oh, sorry. Thank you. We all know the IDF updated new version last year. China is no doubt located in the heaviest diseased area in all of the world. There are more than, if you look at the data, there are more than 96 million people living with diabetes in China, ranks the first place in the world in the year 2013. National prevalence is over 9%, while the undiagnosed rate is over 60%. This picture shows how the economic factors and lifestyles change the prevalence of diabetes in such a big country, such a big developing country. In the year 1970s, people in my country work a lot and eat very little due to the food shortening, and the prevalence at the time was only 0.6%. In the 1990s, while China's economy booming, the prevalence also climbed to 2.5%. Nowadays, it rises to over 9%. As you know, and IDF estimated in 2035, the prevalence will rise to more than 10%. That means 143 million of diabetic patients. The diabetic patients, especially those who suffer from diabetic foot, who are reluctant to go out of home, go to the hospital. Think of the wide rural areas in China. Maybe what we found now is just the tip of China's DF iceberg. So let's focus on diabetic food issues. According to a survey of 4,800 patients, diabetic patients from the year 1994 to 2003, what we found is the diabetic food incidence is about 14.5%, and what we found is the over 26% of diabetic patients has no pulse at the cephalospedias artery. For each diabetic foot patient, the amputation rate is above 10%, and the 30-day mortality after amputation is 10 to 14%. Another message is that pure ischemic ulcer only account for 20%, and 67% of them are infected. When the diabetic foot comes with an ulcer, 57% of the patient only have one, and over 20% have more than two sites. 34% are shallow skin ulcers, and 22%, 6% are deeper ulcers involve the bone. The gangrene rate is 17% in diabetic foots. 49% of them are dry, and toe gangrene account for 88%. Now comes to the treatment. Dr. Armstrong and Dr. Mills put forward and practice the toe and flow concept, which is very beautiful for limb salvage teamwork. We all know that podiatrists play a key role in this teamwork, but it's not easy to copy it into China, since there's even no podiatry in our country yet. And orthopedic surgeons and general surgeons often took the podiatrist's job, but when it related to the vascular things, they don't like it. It's also conceivable that the complications is too challenging or too tough for any physician or even diabetologist to cope with by themselves. And it's also impossible for vascular surgeons to do everything. So that means a huge amount of people, diabetic foot patients, may have no way to go and die of it. Add to this, don't forget, this Asian country have its own magic traditional medicine. In my practice, many patients rarely get help from the combined treatment of vascular operation and traditional Chinese medicine. But maybe it accelerates the wound healing time, but its philosophy is too hard for us to integrate them into our teamwork. In the year 2013 to 2014, it's very lucky for me to visit Tucson and San Francisco to learn from the pioneers of limb salvage, Dr. Mills, Dr. Armstrong, and Dr. Conti, Dr. Reiselman. Dr. Jian also came to China last year and put the concept of SARSA and Wi-Fi to our hospital, which Dr. Jian just explained to us now. So, under the direction of them, we reorganized different divisions to a multidisciplinary limb salvage team. Now it's really different from before, and also different from SARSA. That's what it is now. The main parts of the teamwork is vascular surgeons and foot and ankle orthopedic surgeons, wound care nurses, which I did not put on the slides, but they play a very important role, and the pathologists related to the manufacturers and diabetologists, of course. This simple structure seems to work very well until now. Let's go to one case. That's a very early case. This is a young male patient with toe gangrene and infection. Of course, the CTA shows the occluded SFA and to the TP trunk all occluded. With the anti-infection treatment, we reopened the SFA with stents and ballooning the TP trunk and the post-tibial artery from where communicated to the peroneal artery, which feed the plantar. And then a TPA is done by the orthopedic surgeons since the uncured osteomyelitis. And the patient seems to recover very well. Hope you can see this video. Patient walk freely back and forth on his regular shoes. Sorry, now play it. With treating more and more this kind of cases, it's critical for us to evaluate and diverse our certain patients by their specific presenting status. An effective and universal classification system which could cross our multidisciplinary teams is indeed. As Luke just mentioned before, ischemia treatment alone cannot always improve the clinical outcomes. The three big determinants, wound, ischemia, and infection, can all impact greatly of the possibility of amputations. But little is known whether a certain foot required vascularization first or amputation first, and how we could predict the possibility of amputation even after successful procedure. Luke had introduced the utility of SVS Wi-Fi system, and we believe it could be one solution to these kind of questions. We also investigate the Wi-Fi system in our centers. The object is very simple, that is to see whether it can describe Chinese patients accurately as a universal language, and whether it's useful to predict the clinical outcome. Major amputation, such as major amputation events, reviewed the cases performed from 2012 to 2013 in our vascular surgery center. A total of 164 consecutive patients with complete follow-up were included. Among these cases, 23 patients required major amputation, that is 14% of the total cohort during the 2-year follow-up. Among of that, there are some religious reasons. The Chinese people don't want to die with loose legs. They want to, if the patient has to die, they want to keep the whole body. There were no difference in these risk factors, as you see, but smokers seems very frequent in the amputation group, but it's not significant. There was no difference between open and endo group, but maybe due to the selective bias since it's not a randomized trial. All the study cases were categorized due to the Wi-Fi system stage 1 to stage 4. The difference was observed. 18 amputation cases were observed in stage 4 group, accounting for 78% in all amputation group, while no major amputation was observed in stage 1 or 2. This result of our preliminary study underlined that the risk of amputation increased as the limb disease progress from Wi-Fi stage to 2 to 4. Although the observation study is non-randomized, the retrospective nature and seems still has room for further refinement. It still gives us confidence that new classification is a practical tool in describing more nature of disease burden for limb-subject patients, and we see a bright future for this system in prediction or even decision making. Conclusion. Diabetic and associated diabetic foot ulcer is an emerging healthcare issue in China. It takes team to save limbs, no matter where you treat patients and who treat the patients. Our early results validated the Wi-Fi concept is a valid tool to characterize and classify Chinese patients. Looking to the future, there's still challenge to implement the toe and flow model in China. It requires conceptual change for specialty administrator and patients. Ongoing international collaboration using a common classification system is necessary. Thank you for your attention.